So I'm going to talk about programs in Vermont, specifically about an on-the-ground program where we're implementing some of the concepts you've been hearing about today and earlier today if you went to some of the earlier sessions. I'm going to try to put it in the context of the overall reform efforts that we've been working on in Vermont. So to start with that, I'll just give a little bit of context. We are, of course, in Vermont, a very rural state, but we're also a small state, and this gives you some sense of that each one of these colored areas are roughly aligned with our counties, and we have one hospital, essentially, in each one of those areas. And so we have relatively more, not because we planned it that way, but over time it's evolved to the point where we have a relatively rational distribution of our healthcare services and facilities across the state. We have three major private commercial payers, insurance companies, and two public payers, Medicaid and Medicare. And a pretty good history over the last decade or two of collaboration and multi-partisan work around health reform. As our cost information mirrors that across the country and across the states, despite the fact that we have been engaged in health reform for 20 years or more in a variety of different ups and downs and initiatives, our healthcare expenditures continue to rise and mirror those. Our per capita amount is lower than the national average, but it's rising at a great rate that's greater than the national average. And so today I'm going to talk about what we're doing from the lens of what I've started to call care reform. And so a few of the speakers today, I think over lunch, at least one of the speakers, and in Vermont, we have really started to try to give some organization to the different things that we've done over the years in health reform. So all health reform is not the same. It doesn't mean just coverage reform. It doesn't mean just insurance reform. It means a variety of different things. And even though I'm going to be touching on probably all of these ellipses as I go through my conversation, they're all going to be sort of today through the lens of care reform. I may, subsequent to this, as conferences give me the opportunity, I may create alternative slide presentations that look at reform through these other lenses. So today, care reform. And for us, care reform equals what we call the Vermont Blueprint for Health. So for the last 3 or 4 years, we have been building first through pilot projects, and now over the last 6 months, the legislature passed requirement to take this program statewide by 2013 based on a foundation of medical homes, advanced primary care, foundation with patient-centered medical homes, and community health teams. I'll talk more about these community health teams in a little bit. We have payment reforms that are across our multiple insurance payers, so I'll also focus on that. We have really begun to work hard at trying to break down the silos we have, the traditional silos we have between our public health programs and our clinical health programs through the Blueprint for Health and through these community health teams and our medical homes. We've been focused on a statewide health information exchange, both electronic health record systems in our practices and in our hospitals, and helping those that did not have them get them, and those that did to update them and integrate them, and really robust and important evaluation system that supports a learning health system. It lives sort of in the background. We have worked very hard to not impose new requirements on our providers, and a lot of our health information exchange in the background is going to support an ongoing evaluation, ongoing data, and I'll also touch on that. Just a quick slide to let you know that we've had consistent support both from our administrative branch, Republican governor and his administration. Governor Douglas was here this morning, and through that entire much of that period, from 2004 on, a democratically controlled legislature. We butted heads at times, but ultimately came together to work for moving these issues forward in Vermont. You might notice, if you were to read this carefully, I was disappointed when I reread it again preparing for this, because I may have written it, but it wasn't exactly as, it's not a very good sentence. But anyway, you might, for those of you that have any knowledge of the Institute for Healthcare Improvement, Triple Aims, was what I was hoping to get reflected in the law here. But basically, what we're saying about the blueprint is it is really about the triple aims, which are improving the health of population, improving patient experience with the healthcare system, and finally, lowering on a per capita basis is the way we try to measure it, lowering healthcare costs across that same population. So the Blueprint for Health, this is one of our early ways of trying to create a picture of what we're trying to do. I have a couple other ones as well. We're still working on this, and any suggestions you might have, I would appreciate. I can't really point, but the medical homes around the side, so those are physician practices, patient-centered medical homes. All the other hospitals, all the other providers, social service providers, all of these different entities intersect at some point or another with these new community health teams. These are new human resources, roughly 5 professionals, 5 full-time equivalent professionals on the ground in our communities to support our primary care delivery in our communities. Supported by, and this is our first and important attempt at payment reform, supported by all of our payers in a consistent manner. We have both voluntarily and by law eventually required our insurers to participate in a consistent, common way in these, in the Blueprint for Health, in these community care health teams, and with our investing in our primary care practices. So we start off with the same system we've always had. We're not yet changing the fee-for-service system that we have in our primary care practices. Click again, please. I should click again. There we go. But we're adding to that an additional payment to our practices. These are based on an NCQA, patient-centered medical home scoring model, and I'll show you a little bit of that in a minute. But basically, once a practice meets the floor requirement for this, they start receiving at least $1.20 per patient per month, and it can go up to as much as about $2.50 per patient per month based on their score. This is real money for practices. It works out to be about $30,000, $40,000 per doc, and so it makes people. It creates interests, gets people to pay attention to what we're talking about. In addition to that, our payers are also paying into altogether to support these new community health teams, these on-the-ground resources. There was a question up until about 3 weeks ago about whether Medicare, we might actually convince Medicare to be a part of our state-led multi-insurer reform, and we did learn, if you can click it one more time, we did learn that we were one of 8 states selected by CMS to participate in the multi-insurer primary care practice demonstration project, and so we're very excited about that. Here's a graph that shows how the payment reform works with the NCQA scoring. I'll get into that a little bit more later, and some additional slides about how the community health teams work. So you can see here the community health team, the homes, the payment reform, health information infrastructure, and evaluation, all going to support both the entire population of an area. This started off as a program that was focused mostly on people with chronic conditions. We called it a chronic care initiative. We have now expanded that so that we're talking about the entire general population. But the question has kept coming up about what happens already in your community. You have food stamp programs going on. We have fuel assistance programs going on. You have general assistance programs going on in your communities and across many of the same people that you might be serving in your community. Each one of those is currently servicing a particular subpopulation. They may intersect, but they're also distinct. Our vision for the future, we haven't gotten here yet, is that the community health team structure that we're beginning to set up in our communities will actually grow to encompass all of the service providers within a particular community area. We'll talk a little bit about data now and evaluation. I'm not going to talk a lot. I'd be happy to answer questions. My presentation this afternoon is not focused on our efforts on so much on health information technology, but suffice it to say that it is foundational. We don't succeed in doing the things we're showing you here unless and until we really extend out not only our electronic health systems, but also our health information exchange network, which we're attempting to do on a statewide basis. These are the general areas of tracking that we're looking at in the NCQA scoring system. You can see that it's about patient tracking, care management, patient support, and also performance reporting. And I'll show you a few examples of how we're beginning to both collect the data and show the data to our physicians. You hear over and over again, if you want change, you want your docs to change the way they practice, you want them to improve healthcare delivery, one of the most important things you can begin to do is put data in front of them. And we're beginning to do that. So this is if you go to the NCQA website, you can download this little content and scoring sheet. It will describe a little bit more what this is about. Basically, and we set up this grid over on the right-hand side here, which basically says once you've reached at least 25 points, the level 1 of the NCQA score, then you would start to qualify for those additional payments that I described earlier. Level 2 starts at 50 and level 3 at 75, and you work your way up that graph I showed you earlier. And for the sake of time, I won't go into these, but if people have questions about what some of these measures are, we'd be happy to answer those questions. Building a learning health system. We don't see this, I'm going to go back to that one for just a second. We don't see this as a research project. We're really thinking about it in terms of transforming our healthcare delivery system, our healthcare system generally. So we're not looking to do evaluation. We're not looking to do a study and write a report for the New England Journal of Gobbledygook or whatever it was that the gentleman said earlier. We're looking on the ground to transform the way, to invest in our primary care system and transform the way that we deliver health care. So how do you do that? You need to do meaningful and useful evaluation. What does that mean? I'll show you a little bit. You need to provide data as part of the routine operations in a physician's practice. Current disease management programs that you might know about from your health insurance companies, they have distant nurse call centers. They call in, they provide, after the fact, pieces of paper to the physician practice, and pretty much to a person, doctors I've talked to say they get those pieces of paper, they don't really know what to do with it. They don't have a way to deal with it. It goes, goes in the trash or maybe in the recycling bin. So how do you provide data as a useful part of the operation of a practice? The metrics have to be meaningful. So what would they be? You have to sit down with people. You have to reach some consensus around what it is you're going to measure, what's going to make a difference for them. You have to create reports that are useful and flexible and actually can work with the practice environment. And finally, you have to have people and processes that will use the information to make improvements in the practice. And so we've found that a lot of the work in making change happen is actually the real detail work that goes on in a physician's practice, right from the receptionist to every other staff person. The way people start to flow through practices is different with both the IT infrastructure and with the health team infrastructure. People start getting referred to health teams and back again to social services. It takes a whole different mindset about how medicine gets practiced at the community level. I'm not going to spend much time, and these are just the various data sources we use. They, for the most part, either we're creating systems for them to happen automatically, or we have external independent people to do the chart reviews and some of the scoring that goes on to leave the practice of medicine, to leave the practices to be focusing on the practice of medicine and changing some of their flows and systems to produce this change. So these are some of the reports that we get through our registry software system that's called DocSite. And basically, this would be one of the first reports that a doctor would see, which tells her or him how many of their patients are in which categories, how many hypertensive patients they have, how many diabetics do they have. Everybody in their practice would be signed up over in this biggest bar to receive health maintenance services. So this both would tell a doctor very quickly how many of which kinds of patients they have, and so which ones are going to be organized and set up to perform different services. This is an example. I took 4 or 5 slides from about 30 that I could have shown you on how DocSite works and the kind of information that gets presented to docs. This is the patient handout they would leave with. They both have to look at in the offices, but also leave with this information. It gives, in this case, some information about trend levels on their hemoglobin A1Cs and their blood pressure. This is an outreach report. This was a report that would get generated for the office staff and for usually the mid-level professionals, and it would list the patients. You can see all the names and numbers are X'd out here, but it lists the patients that need some attention for some reason or another. They haven't been in the office. They haven't gotten the tests they need. The result might have come in and it was above where it should have been or below where it should have been. They would come up on the next outreach report, and this would actually lead to phone calls or other interventions to those particular practices, those particular patients. And this is one example of it's a body mass index data for a patient population. And so this tells a doctor that has started on this program that over time they now have increased it to about a little more than a third, from almost 0, the number of patients with a body mass index result in the record system over the last 12 months. That's represented in blue. Purple are still those without, so they still have work to do. You can begin to get all kinds of different reports. This shows both average. Again, this is A1C results for diabetics. And you see in the box there, you'll get an average score across your diabetic population. And you can also begin to see distribution of who's where along the A1C spectrum here. And so you've got people in the green categories over on the left that are doing a good job of managing their disease. People in the middle, as you might have guessed, are in the middle, and those over to the right are those with real problems. So this can really begin to help the doctor focus in, and the staff focus in on who needs their attention and what's going on, and they can begin to break this down and work more effectively with their patient population. This is my favorite slide in the whole thing, especially as a policymaker. I wanted to know what the results were going to begin to look like. And so the blue lines were the existing trends. These are ER visits on the top, and the bottom are total hospital admissions in the two most advanced pilot areas that we have in the Blueprint for Health. So you can see the blue lines are the older trend lines. The pink ones are the new trend lines. So we're seeing lower incidences of emergency room visits, lower incidences of hospital admissions, and from my standpoint, that's, and I think from all of our standpoints, that's good news for the patients, good news for the practices, and also, obviously, good news for the cost in our healthcare system. We've modeled this both early on and for our entire state, and we believe that over the next several years, as we roll this out statewide, we will see something in the order of at least this 28-30%. This chart, if you read over there on the left, it's the annual change in healthcare expenditures. So it's not total expenditures, it's the annual change. So in Vermont, it might be similar to in your state, healthcare costs, the easy way, they go up about $350 million a year, or about $1 million a day. So every day that goes by, current trends goes up by about $1 million. We think we're going to cut that down by about 30% over the course of the next 5 years. That increase, it's still going to be going up. So rather than going up by $350 million a day, it'll only be going up by $300 million a year. Excuse me. And the disturbing news, of course, is even if we are that successful, completely successful with the modeling in this, we're going to see about a 2% reduction in the total cost of care, the total expenditures in health care. Real money, this is something like $120 million a year or more, and that's a lot of money for Vermont, but still, we're looking at some very, as you know, some very strong, persistent forces that are increasing the cost of health care. We're looking at the federal reform as a real opportunity for us. We've been in the middle of reform actively since 2006. We've had a legislation each year. Some of our coverage initiatives go back 15 or 20 years. Some of our insurance reforms go back a similar period of time. So Vermont is a state that's been invested in the idea of health reform. So we are seeing the federal reform as a real opportunity to move reform forward. You've heard just in the previous speaker about all of the funding opportunities that are in the federal act. We are actively pursuing those, and really, along with that and the Medicare, the CMS approval that I mentioned earlier for the multi-payer advanced primary care practice demonstration project, we believe as positions Vermont and other states that are moving aggressively to really be able to move the agenda forward over the next several years. This is our schedule for achieving statewide expansion of our integrated health system reforms. And this is just one not so simple example. This is hard, complicated work. And this is an example on health information and quality infrastructure about how we have been and in the future see ourselves working with the federal government in a way that is really more of a partnership and is going to make this all work together. So at the national level, you'll have guidelines and funding and guidance feeding into state-led reform efforts. We are currently in the process of for various different disease states, diabetes and other things. We're also about to head into mental health and home health and some other areas, beginning to put together clinical process data elements, health status elements, aligned measure sets. These are all things that you need in order for your electronic health system to be able to exchange data, to be able to do the sort of reporting that I've shown to you. And basically all these different pieces feed into each other to produce guideline-based health services and real patient care on the ground. On the other side, you have the reporting and evaluation function, quality improvement, and reporting and data, continuous improvement, shared learning, and that the objective, the goal here is an ongoing learning health system. So just, I'm starting to bring this to a close, but just to go back to this chart and to make the point again that while we've been looking at this through the lens of transforming our healthcare delivery system, through the lens of investing in primary care and preventive care, that we're also, in order to do that, we really need to be focusing at the same time in many of these other areas as well. So our care reform efforts are dependent upon payment reform, they're dependent upon infrastructure reform, and they feed directly into the coverage reform initiatives that we have. So future challenges and opportunities, we all know that ATM over there is really our biggest challenge in this. How do we change what we're doing and really focus on improving the value in our healthcare system for the amount of money that we're paying? I agree with many people who say there's plenty of money circulating in the healthcare system. We just need to be redirecting it and really focused on the value that we're getting for the money we're spending. Future challenges and opportunities, I've been mentioning costs. Maximize the benefit to your state, in our case to Vermont, of federal reform. There's a lot there. There's a lot to choose from. It's going to make different things are going to make sense for different states. Workforce issues you've already heard about, very important to keep your eye on that ball. Payment reform, we've started that with our blueprint for health communities, with our primary care medical homes, and we're looking very hard at the ACOs and other related more systemic payment reform initiatives. Sustainable financing, if all you do is focus on coverage reform, you getting people covered. If all you do is you work on the exchange and you get do your Medicaid expansions, you're gonna. I think it's probably already clear to you, but it's very clear to us that have gone forward with some of these things already that we are not going to be able to afford to keep everyone covered if we don't simultaneously start working on some of these other parts of reform, care reform, payment reform, infrastructure reform. It's just not going to be affordable. And for us, we passed last legislative session this gives you a sense of the political landscape in Vermont. So we have going on right now a preeminent scholar from Harvard doing an extensive system evaluation in Vermont. The report is due January 1st. And to provide a system view of what we're trying to do, he's supposed to look at it from a single-payer approach. He's supposed to look at it from a public option approach as a second option. And then he's designing at least one other option that is, in his opinion, to be a more pragmatic and politically achievable way of designing our healthcare system. So we're also waiting for that in Vermont, and we hope to. The way he described it to us when he started was, he said, in Vermont you actually have you've done a lot, maybe as much or more than many other states. You have a lot of the pieces. He said, I like to think of it that you have you've developed a lot of the pieces of a quilt, and a lot of them are very good, but you don't really know what what the design of the quilt is. You have a lot of the parts, but you don't know what the whole looks like. And so he's doing this work for us to give us some options on what the whole of the healthcare reform and system could look like in Vermont. We hope to be a model for the rest of the country. We need to be careful. I think that was part of the message at lunchtime as well. Be careful about what we do and how we do it, the data we get, and the things we try to do, and not do too many stupid things all at once, which is what we've tended to be doing over the last period of time. And we'll end there. It's time to listen too. So thanks very much.